renovascular diseases, open surgical and endovascular management. Following Goldblatt's innovative work defining the causal relationship between the renovascular disease and hypertension in 1934, the surgical management of renovascular diseases evolved through three eras: nephrectomy, open surgical resection, and followed by renal artery angioplasty with or without stenting. And this is the timeline showing the evolution of the surgical management. In 1930s, they did nephrectomy for hypertension with a small kidney. And when as the time progressed in 1970s, the renal duplex came into the picture. In 90s, CT angiography and MR angiography came, and in 2000s, in Europe, trials, Coral, Astral was done, and this is the timeline showing that. And when coming to the indications for surgical repair, severe refractory hypertension, that is uncontrollable hypertension even after 3 to 4 antihypertensive medicines, and bilateral or global atherosclerotic renovascular diseases due to high-grade stenosis, that is more than 90%, or renal artery occlusion, and severe hypertension with rapidly deteriorating renal function, and children with hypoplastic lesions. And coming to the surgical techniques are divided into two main things. One is direct and indirect. In direct surgical techniques, aortorenal bypass, thromboendarterectomy, and renal implantation was there. And in indirect surgical technique, a splanchnic renal bypass, hepatorenal bypass, splenorenal bypass, and EXVIVO reconstruction. During surgical reconstruction, all hemodynamically significant renal artery disease is corrected as a single operation, and diseases requiring bilateral ex vivo reconstruction are done as a staged procedure. And the nephrectomy is reserved for the non-functioning kidney, that is less than 10% of the nephrons are functioned by functional renography. And direct aortorenal reconstructions are preferred to indirect methods because concomitant disease of celiac axis is present in 40 to 50% of the patients, and bilateral repair is required in half of the patients. Before going to the surgical techniques, we must know the anatomy of kidneys, and they are usually located in the L1 and L2 intervertebral space and enveloped in Gerota's fascia. And the left kidney is located behind the spleen and tail of the pancreas. The right kidney is behind the duodenum and hepatic flexure of the colon. When coming to the positioning and incision, supine position at umbilicus at the level of table split is good, easier to access inflow and outflow vessels, and the midline incision is used for operative repair of bilateral atherosclerotic disease, or when combined aortic and renal repair is planned. When subcostal incision is used when a branch renal artery repair is required, or when ex vivo technique is used. Coming to the technique, mobilize the retroperitoneum. We give midline exposure and start with the white line of told and stay always anterior to the Gerota's fascia. For exposure of the right kidney, mobilize the duodenum head of the pancreas by coccus maneuver, and for the left kidney, splenophrenic and splenorenal ligaments and tail of the pancreas we mobilize. And this is the technique showing here. They give the incision posterior peritoneal incision line at the base of the mesentery, and this gives the exposure of the aorta and left renal hilum through the base of the mesentery, and the extension to the posterior peritoneal incision to the left along the inferior border of the pancreas, and provides entry to the avascular plane posterior to the pancreas. Basically, this gives a good exposure of the left renal vein first. When we retract the left renal vein superiorly, then we can see the left renal artery. And coming to the exposure of the right renal artery, right renal artery we can see at the base of the mesentery, and proximal right renal artery is seen at the base of the mesentery, and mobilization of the left renal vein by ligation and division of the adrenaline, gonadal and lumbar veins allows exposure of the entire renal artery to the hilum. On occasion, the lumbar veins are ligated and divided to allow the retraction of the vena cava to the right. So this is the same picture showing multiple accessory renal arteries. When we see the accessory renal arteries, they should be preserved. And the right renal vein is typically mobilized superiorly to expose the distal renal artery. We can see in this picture. Coming to the aortorenal bypass, The most commonly used graft materials are autologous saphenous vein, autologous hypogastric artery. Autologous hypogastric artery is used in children with hypoplastic lesions, and synthetic graft with a 6 mm thin wall PTFE graft. If the vein is small, less than 4 mm in diameter, or sclerotic, the hypogastric artery or synthetic graft may be preferable. This is the image showing the itorenal bypass. And when the distal anastomosis is usually done end to end or end to side, and for the distal anastomosis, arteriotomy should be 3 times the diameter of the artery to prevent a recurrent anastomotic stenosis. And for the anastomosis, we use 60 or 70 proline with the magnification loop. When coming to the next procedure, thromboendarterectomy. In case of ostial atherosclerosis of both the renal artery origins, simultaneous bilateral endarterectomy by either transaortic or transrenal approach is used, and transaortic endarterectomy is performed through a longitudinal aortotomy with sleeve endarterectomy of the aorta and eversion endarterectomy of the renal arteries. The aortotomy is closed with 50 proline as a continuous suture. And thromboendarterectomy is contraindicated by the presence of pre-aneurysmal degeneration of the aorta and transmural calcification. Aortic atheroma complicated by transmural calcification resembles fine-grade sandpaper and palpation of the outer surface of the aorta. This is the technique showing thromboendarterectomy. Here the exposure is normal by routine maneuvers. The duodenum is mobilized at the ligament of Reed in standard position, and then the ascending colon and small bowel are mobilized. Here the picture in A, the dotted line shows the location of the aortotomy. The plaque is transected sharply, and with the eversion of the renal arteries, the atherosclerotic plaque is removed from each renal ostium. The arteriotomy is typically closed with 40 or 50 proline material. Coming to the reimplantation, when the renal artery stenosis is orificial and there is sufficient vessel length, the renal artery can be transected and reimplanted onto the aorta at a slightly lower level. This is the technique when the renal artery is redundant, the vessel can be reimplanted at a lower level. When coming to the indirect surgical techniques, hepatorenal bypass, a right subcostal incision is used and the lesser omentum is incised to expose the hepatic artery, and duodenum is mobilized by Cocker maneuver, and IVC and renal vein are retracted to expose the renal artery. Proximal anastomosis is usually made to common hepatic artery, and the renal artery is then transect and brought anterior to vena cava for anastomosis. Sometimes we can use graft also for the anastomosis. Splenorenal bypass. Here we use midline or left subcostal incision. Here the pancreas is mobilized by reflecting the inferior border upwards, and the splenic artery mobilized from left gastroepiploic artery to the level of its branches, and the left renal artery is exposed, and the splenic artery divided distally and spatulated and anastomosed end to the transected renal artery. This is the image showing the exposure of the left renal hilum in the preparation for splenorenal bypass, and the pancreas has been mobilized along its inferior margin. When coming to the EXVIVO reconstruction, EXVIVO reconstruction is used for repairs more than 40 minutes. Here vessel loop or a soft plastic bulldog for ureter to prevent collateral back bleeding, and perfusate that matches the intracellular composition of electrolytes. The usual perfusate that used in is 500 ml of ringer lactate at 4 degrees Celsius, along with the heparin 1000 units plus 10 to 12 mg of mannitol plus dexamethasone 6 mg plus 30 mg of papaverine plus 25 mg of sodium bicarbonate. This is the usual composition maintained at 4 to 5 degrees Celsius temperature is used, and then Girota fascia is opened with a cruciate incision, and the kidney is completely mobilized and the renal vessels are divided. To perform hypothermic perfusion, the kidney is placed in a plastic sink and the renal artery perfused with a chilled renal preservative solution. The chilled solution is hung at a height of about at least 2 meters in height, and Immediately after its removal from the renal fossa, the kidney is flushed with 300 to 500 ml of solution until the venous effluent is clear and all segments of the kidney have become blanched. As each anastomosis is completed, the kidney is perfused with an additional 100 to 200 ml of chilled solution. During the entire procedure, the core temperature of kidney should be maintained below 10 degrees centigrade. This is the image showing an ellipse of vena cava containing the renal vein origin, exercised by placement of large partially occluding clamp and then the anastomosis. And coming to the results of the surgical techniques, the anatomic results are postoperative stenosis or thrombosis occurred in and 3.3% of renal open surgical procedures, and the recurrent hypertension and declining renal function is observed in 3.7% after a follow-up of 36 months. And coming to the operative morbidity and mortality, morbidity is seen in 15 to 20% of the patients in the form of dependence on dialysis, and mortality is seen in 0.8% of the patients in isolated renal artery repairs and 1.6% of the patients in bilateral renal artery repairs and 3.3% in bilateral repair combined with aortic repair. When coming to blood pressure response, the criteria that used for evaluating the response are blood pressure measurement and medication requirement at least 2 months after the procedure. 85% of the survivors had been cured or improved of the blood pressure, and 15% had no blood pressure response. In renal function response, 58% of the patient demonstrated improved renal function at 3 weeks after the repair, and when 45 patients are considered permanently dependent on dialysis before the procedures or examined postoperatively, 70% of the patients were permanently removed from the dialysis after the open operation. In coming to the survival benefit is there with the patient successful outcome and in there is improved renal function. Then this concludes my surgical treatment. And coming to the endovascular treatment, there are two important trials conducted in Europe are Astral and Coral trials. And Astral trial is angioplasty and stenting for renal artery lesions, and Coral is cardiovascular outcomes in renal atherosclerotic lesions trial. Both these studies demonstrated there is no evidence to support the widespread application of renal stents to the patients with renovascular hypertension or ischemic nephropathy. But the indications are usual indications that used for stenting are chronic refractory hypertension and renovascular patients associated with declining renal function and hypertensive emergencies associated with the target organ damage like flash pulmonary edema, hypertensive encephalopathy, myocardial infarction, and renal failure. The contraindications for endovascular treatment are mostly the anatomic reasons, like anatomic regions like renovascular disease extending into the terminal portion of the main renal artery, and renovascular disease existing in the branch arteries beyond the main bifurcation, and lesions in multiple small renal arteries, and lesions in children, mostly hypoplastic, where open surgery is preferred. And coming to the results of the endovascular treatment, definition of success is criteria for procedural technical success include reduction in stenosis as assessed by completion angiography and complete coverage of the stenotic lesion by the deployed stent, and post-intervention residual stenosis of less than 30%. And persistent systolic gradient of 10 mm of Hg are more suggestive of inadequate treatment. And coming to the outcome measurement, early outcome technical success rates are range from 88% to 100% is observed, and peri-procedural 30-day mortality was 0 to 5%, and procedure-related complications occurred in 0% to 43% of the patients. And late outcomes and hypertension response. In an Astral study, there is no significant improvement in systolic blood pressure when compared to the medical therapy, and a modest decrease in diastolic blood pressure and a statistically significant decrease in the number of antihypertensive medications was observed in astral study. In coral study, a small but a significant decrease in systolic blood pressure was observed with no resultant decrease in the number of antihypertensive medications. And when coming to the predictors of hypertension response, preoperative duration and severity of the hypertension, and age of the patient, and percentage of the stenosis, and bilateral disease, and female general. When they are younger, there is good response with the stenting procedures. And coming to the renal function response, and there are case reports that suggest that 25% of the renal function there is improvement in patients with the stenting, and roughly equal proportion experiencing the decline in the renal function. These studies demonstrate that the plasty and stenting can reduce the rate of renal function decline, but not this. In astral group, no benefit in slowing the rate of renal function is observed when compared to the best medical management alone. When in patients associated with improved renal function, there is improved survival. And coming to the renal artery stenosis after intervention, reported rates of restenosis after stenting range from 5% to 66% and vary with the duration of the follow-up. And restenosis is more common in women and in patients with metabolic syndrome, and other factors that include misplacement of the stent and inadequate proximal coverage of osteal lesion and the stent fracture and severe calcification resulting in stent compression. And coming to the technique used for endovascular stenting, we should know that renal ostia in anterior-posterior view, there is a pure opacification of the origin. So we need to use oblique imaging. It needs to correct the artifact resulting from the contrast overlap between the aorta and proximal renal artery. And the multiple renal arteries are present in 18% of the cases. We should remember that before going for the procedure. And in operative planning and the prophylactic strategies for prevention of contrast-induced nephropathy are give pre-op hydration using isotonic saline and administration of N-acetylcysteine as a renoprotective agent, and routine use of isoosmolar non-ionic contrast material at the lowest volume possible. And coming to when we should do plasty or plasty along with stenting, the stenting is associated with superior technical success than the balloon plasty alone, and the incidence of recurrent stenosis is also low in stenting. The axis is used is contralateral femoral axis is ideal, and the brachial artery axis is used in patients with aortoiliac occlusive disease. Angioplasty and stenting, and the access can be gained by the use of selective catheter in the form of a guide catheter or diagnostic catheter, and the tip of guide sheath or catheter is positioned at or within the orifice of the targeted renal artery, and guide wire is passed across the stenotic lesion. Usually 1/4 wire with a floppy tip is used for crossing the renal artery lesion, and these are some selective catheters routinely used for in renal artery stenting procedures. If a distal embolic protection is being planned, and use a wire system that is incorporating distal renal artery occlusion along with balloon or filter is used for crossing the lesion and is subsequently deployed distally. And the pre-dilatation usually is done with 2 to 4 mm balloon at 20 mm pressure, 20 mm length, and low profile balloon to a nominal pressure for 15 to 30 seconds. And the stenting is most commonly performed with the balloon expandable stents because they have greater radial strength and then can be deployed with precision at the ostia. And the stents are placed usually with 1 to 2 mm of extension into the aorta for treatment of ostial or proximal disease. If residual waste is visible on fluoroscopy, then the narrowed area can be post-dilated with an appropriate balloon size. This is the image showing the renal angioplasty and stenting with the distal renal artery balloon occlusion for embolic protection. And you can see a static column of contrast material is visible proximal to the occlusion balloon. Here we can see the wasting of endoluminal stent, and here post deployment dilatation is required. When coming to the post-procedure management, and clopidogrel is usually continued after intervention for a minimum of 30 days. Aspirin and statin therapy is continued indefinitely, and follow-up at 1 month and every 6 months for 2 years, then annually with the duplex ultrasonography is required. And the renal artery peak systolic velocity of more than 180 centimeter per second is suggestive of disease recurrence. Then we need to follow that patient with a routine angio, CT angio. Then if there is no hypertensive, then no need to do any intervention. We can treat that patient medically. But if there is severe hypertension, then we may need to do a secondary procedure. And coming to the complications, accessory hemorrhage and accessory pseudoaneurysm, bowel extremity ischemia and renal artery thrombosis, acute renal failure, and retroperitoneal or perinephric hematoma due to the rupture of the renal artery. And this is the CT image showing the retroperitoneal pseudoaneurysm resulting from the renal artery rupture, angioplasty, and stenting. Thank you.